Okay, we have a quorum. Let us call the meeting to order immediately, because we don't want to keep the deputations waiting. Thank you for coming, members. Today we are here mainly to listen to deputations today, but we're also going to talk to the administration. Now let us invite the officials and the deputations to come in first. As you can see, we have some new papers tabled just now. That's CB bracket 2, 1580, bracket 06 and 07. In fact, some of the other papers that sought to respond to our previous questions are also with you. Perhaps we won't have time to go into those papers because we'll first listen to the deputations. Maybe we'll address those later on. Mr. KK Kwok has written in to invite the Privacy Commissioner to attend the meeting today. But because this is a public hearing, the Privacy Commissioner has also attended. But I believe you will have other questions for him later on. If that's the case, we can see whether we will see the Privacy Commissioner again. Is that okay? Well, yes, today we need to provide deputations with the time to speak, so I can't see how we will have time enough for the Privacy Commissioner. Maybe we should invite him again because that will be fairer. I believe this has so much impact on people's privacy. All right, maybe after today's meeting we can give the Privacy Commissioner some time, since we should really respect him. Well, yes, but he has also written in as one of the deputations, so he will be given the time to speak, but later on we can invite him to come back. Ms. Emily Lau, I tend to agree with KK Kwok. I think the clerk should exercise caution. Now, of course, when we have an open invitation, people will come and each will be given 2 minutes, 3 minutes. But when we invite the EOC or the Privacy Commissioner, we should give them some special arrangements, because the average member of the public is given 2 minutes. However, the EOC is also given 2 minutes. I think they should be given a different treatment. And it's not just for this meeting. I think the Secretariat should have an internal discussion. I agree with KK Kwok. Of course, we welcome the Privacy Commissioner, but he is a statutory office, and I think it should be given more time to speak. I hope the Secretariat will discuss this point. If there are these statutory bodies, they should be given more time. Thank you, Ms. Lau. Actually, don't just talk about the Secretariat, because they discussed with me, and in fact, it was my decision that the Privacy Commissioner should be invited as one of the deputations, but we can always invite him to come back. There are 22 deputations and individuals attending the meeting today. 2 deputations are not attending, but actually 1 deputation and 1 individual, they are not attending, but they have submitted written statements. I'd like to remind the deputations and individuals attending the meeting that you can use the microphone and also the earpiece. The channel 0 is floor, channel 1 is Cantonese, channel 2 is English, and channel 3 is Putonghua. You can check the machine if you need interpretation service. Also to remind deputations and individuals that whatever you say here will not be protected or exempted under the Legislative Council Powers and Privileges Ordinance, Cap 382. In other words, your submissions and also your oral remarks will not be covered by that ordinance, and you will have to take responsibility for what you say. Also, I'd like to remind deputations and individuals that within the Legislative Council building, if you are attending the meeting or in the gallery, there is a notice issued to you, and which has been attached to the correspondence with you before the meeting. It has also been tabled, but I don't expect any particular behavior today. If you need a copy, you can ask the security guards for a copy. Because of time constraint, in the first round, we are going to invite deputations and individuals to speak first, but you will only get 3 minutes each. Now, of course, if you have given us a submission, then you do not have to repeat what you have said. Please do not read it out, because we will be able to read it. Please only add new points or highlight the main points in your submission. So first of all, can I invite the Hong Kong Alliance of Patients Organizations, Mr. Zhang Kin Peng. Thank you, Chairman. The Hong Kong Alliance of Patients Organizations support an EHRSS or sharing system. We believe there is a need to legislate for this, that we should have an independent piece of legislation away from the PDPO to regulate the EHR sharing. Our biggest concern is as follows. Number one, public service and how it is balanced against the individual's rights. If we look at the bill here, in 5.2 ABC, we can see that later on, the Commissioner will have absolute powers. If we want to use the system, everything that the Commissioner requires us to provide will have to be provided, but there will be no limit to the retrieval of the information. In other words, we being the data subject will not be able to limit what information can be retrieved by others. So I believe perhaps we need a kind of safe deposit box mechanism, because as the patient, whether we want to disclose all information about ourselves, particularly sensitive health information, that should be subject to the individual's choice. However, if I take part in the system and then I'm compelled to reveal everything about me, then I believe that is not a very good balance. So perhaps we need to set up a kind of safe deposit box mechanism, and highly sensitive individuals' health information should be kept in that box, and whether it can be retrieved should be decided by the data subject. Another point. If we look at the bill again, number 46, 47 and 48, later on the EHRSS will be administered by the administrative departments. The information will rest with the Commissioner. And then if you look at clause 29 of the bill, all the data, apart from public health and research, can be used as permitted by or under any other law. Now on this point, of course, we may know some uses beforehand, but then some uses may not be known now because we don't know what legislation there will be in the future. But then the data will rest with the administration instead of with doctors. Now, we believe there is some worry here. As for the rest of the bill, our views are in the submission already. Please just read the submission. Thank you.
Professor John Bacon-Shone.
Thank you very much. Again, you have my submission, so I will not read out what's already there. I think the critical point is I want to highlight two of the points which the Privacy Commissioner has made in his proposal. The first one, of course, is that this must in no way weaken any of the protections that are already enshrined in a personal data protection ordinance. The second one is similar to the previous speaker. I believe that insisting on consent being on an all or nothing basis, and in particular where they are not going to develop till the second stage, the patient access to their information, is quite unacceptable. I believe they truly do not understand either the principle of fair collection in the Personal Data Protection Ordinance, which means you must understand the risks, and similarly the principle of informed consent. So informed consent without telling you what the risks are is clearly not informed consent. So in a situation where the hospital authority system may hold more than 20 years of people's medical records, this is a serious matter. Patients may well not even know what they're agreeing to share if they agree to share, and the fact that they have no mechanism to allow them to restrict what is shared. In fact, if you look at the UK, in the UK, the whole plan system is now being put on hold precisely because patients have realized what's going on and that they will have no control over their data once they've agreed to the system. So there has been uproar there for exactly this reason. So I find it ironic that they quote the doctors in Australia's concerns when in fact there are far greater concerns from patients in the UK for this sort of system. The other 2 points I wanted to highlight is there is no indication here they understand re-identification risk. So in other words, the fact that the data has had my name and ID card number removed in no way means that it's safe now or in the future from re-identification and rematching back to me. So simply assuming that because the data has been anonymized now it is safe for research is a false assumption. So it must be necessary to have just as serious a review to see whether there is a privacy risk or re-identification risk. And indeed, the whole process for review of research access is largely absent from the legislation. We are left to guess what the composition of the review board will be. And in fact, if you look at how the institutional review boards work inside the hospital authority, the implication is that it will be dominated almost entirely by doctors with little representation of other healthcare professionals, let alone representation from people who might balance that. Because the responsibility of that review board is to balance the medical benefits with the privacy risks. But that means you must have a balance in the composition. So to leave the composition entirely undefined, I would believe, is also unacceptable, and it's likely to lead to unfair decisions and unsafe decisions being made. Thank you.
Thank you, Professor Bacon-Shone. 下一位
Next, Senior Citizen Home Safety Association, Ms. Young. Thank you. We've already made a submission earlier, and also where we provide service for the elderly at the moment, our association can already access the eHealth. In providing service, we believe that this can help us provide better service for the elderly. Of course, I understand the privacy implications. In our association, only professional nurses can access such records. You really need to access the records. In the process of doing so, we need to ensure that we need the access before medical staff can provide the proper medical service. Perhaps we can further compartmentalize the data that can be accessed. For the professionals, they can have full access, but for data involving sensitive diseases, we can have further compartmentalization so that some people will only have partial access. Thank you. Thank you, Michelle. Next, we have Mr. Chen Hiu Ming from the eHealth Consortium Limited. Chairman, we don't have anything new further to our submission. Okay, then we have time to ask you questions. Next, Madam Lui, Jun Lui. Regarding the design and development of the EHR sharing system, I think the government has done a very meticulous job, and we really commend the administration for that. We're now making a new start here, but to ensure that at the second stage, I think we should study further into the question of safe deposit box. If possible, the government can collaborate further with the electronic industry in order to allay some of the concerns. Some people suggested that the EHR sharing system, and that through this platform people can access their own medical records through apps and so on. I think there might be some misunderstanding here about electronic health record. There might be some additional risk. At the second stage of the study, we hope that the government can work together with the industry so that we can come up with a proper solution so that, well, on the one hand, we can make it convenient for the public to access the information and also to reduce misunderstanding. There are 13 categories of medical staff that can make use of the sharing system, including the Chinese medical practitioners, listed Chinese practitioners. But however, some TCM practitioners are not used to storing medical record electronically. In the past, we've worked with the government. We've organized many training courses for TCM practitioners, and we understand that they really support this proposal. We suggest that the government can implement more training programs on EHR so that more TCM practitioners can use the system and store their medical record electronically. Our Alliance hope that the system can help improve the quality of medical service and the public will benefit. Thank you. Thank you, Ms. Lui. Next, we have Ms. Chu from the System 8 Medical Services Limited. Thank you. We are a support organization for clinic management. We help doctors to convert the medical record into electronic formats. In our business, I think last year we conducted a survey, we conducted a telephone survey, and we found that at least 1/3 of the private practitioners are still using handwritten medical record. Hong Kong has a very advanced medical system, and despite that, many practitioners are still using, index cards and handwritten medical records. And that's why we really welcome the government's proposal for the EHR. So, first of all, the doctors would need to use computers before the records could be shared. So we really support the government's proposal for electronic health record sharing system. After the government has enacted this ordinance, we'd like to know what steps the government can take to support those practitioners who are still using handwritten medical records and try to help them use computers before we can really implement the EHR scheme. If not many doctors are willing to really work in tandem with the government, how can the government ensure that more doctors are willing to use computers to keep electronic medical records? We also support the second stage of the EHR sharing system. We hope that the patients can have a login number so that they can access their own medical record. I agree with the other deputations, that is, the patients should have the right to select certain sensitive information which they don't want to be shared, and that patient should have the right to make that choice. Next, Ms. Leung Wing Man from the Civic Party. The Civic Party welcomes the proposal to set up the EHR sharing system, but we believe that bill as it stands is not perfect because the privacy of patients are not sufficiently safeguarded. Before the bill is further improved, the Civic Party will not agree with to support the bill. What we are most concerned about the bill is that there is no definition as what is meant by health record, and that they should be disclosed via the system. Should it include the entire medical record of the patients, including X-ray examination results, whether the patient is allergic to certain drugs, or whether or not the more sensitive information will also be disclosed. Unless the government can come up with a clearer explanation, otherwise the public will not have sufficient protection. Most of the medical record will not need to be disclosed to medical staff. For example, the patient may have asked the doctor for some psychiatric consultation or venereal disease and so on. Normally, for other typical diseases, there is no need to disclose such information. If they were disclosed, it would be an abuse. In 2008, airline company forces employees to authorize the company doctor so that the company can access the staff's medical record. And this shows that in future, the EHR sharing system, once implemented, would mean that so long as the general public agrees to the sharing of the medical record, company doctors can very easily access the staff's full medical record. We therefore believe that the bill as it stands does not provide sufficient safeguards for the public. The public can only choose either to join or not join the scheme, or either not joining the scheme or fully disclose their medical record. To protect the privacy of doctors, we need to have a safe deposits box system so that the patients can set a limit on the information that can be disclosed. The electronic medical record is personal data of the patients. Which kind of data should be disclosed and so on should be up for the patients to decide. The safe deposit system allow the patients to keep the more sensitive information into the safe deposit box so that there is a restriction on access, and the public can disclose corresponding medical record to different medical professionals so that the privacy will get the maximum protection. Next, we have Dr. Ann Kwan. I represent the Hong Kong Medical Association. Nowadays, medical examinations and tests are getting more and more complex, and patients are different drugs. And the cost is now higher, and also there's a high mobility on the part of the patients. Many patients tend to patronize both private practitioners and public hospitals. So keeping medical record in handwritten form is not able to help us, do a good job. The HA has an information sharing system, which is a very good system. For private practitioners, we can access all the records in public hospitals, but this is only one way. In other words, the private practitioners can access the records of the HA, but the public hospitals cannot have access to the information retained by private practitioners. For example, allergy. Say a private practitioner may dispense a drug and the patient is allergic to that drug. There's no way for him to upload the information. So we hope that there could be a data sharing system. So using the electronic platform is a very good way. We therefore fully support the scheme. However, we would demand that the privacy of the patient should also be safeguarded. The data protection principle should also be respected, and also the IT system would need to be highly secured. Regarding the safe box proposal, I have some reservations. For doctors, all information to us are important. We will not easily disclose any such information. And it's not just information about venereal disease, AIDS, and so on. We'll never disclose that to a third party. To install a safe deposit box there and I can access the information inside would mean that I know something is there, but I don't know what it is. Then I think that is problematic. And thirdly, by looking at the drugs prescribed, I would know what sort of disease that the patient is suffering from. So I think we need mutual trust here. So for the time being, I have some reservations about safe deposit box system. I also like to stipulate that not all information can be shared. Thank you.
Next, Dr. Yang Chiu-fan from the Hong Kong Doctors Union. As a registered doctor practicing Western medicine and also as a person holding a bachelor's degree in computer science, I of course like the system, but I am here to speak on behalf of my members. Just now Ms. Chu said that 1/3 of Hong Kong doctors handwrite their prescription. But actually we have done our survey and only a quarter use the computer and 3/4 use handwriting. We have 2,000 members. Most of them are in private practice, and fewer than 500 use the computer to prescribe, do prescriptions. And so not many of them are going to participate in EHR. We have asked them why, and they say this is because of the quantity issue. Now there is an explosion of data, and when doctors read computer papers, there are many pages, and they don't know which information is useful. And then there are 12 other professional bodies which can upload the information. So the doctors may be flooded with information, a lot of which is not useful to him. Secondly, quality. What I mean is, the bill says that the commissioner doesn't need to take responsibility for the data, that is, whether the data is real. If the doctors are inundated with information, yet they don't know what is real, what is not real, so if they use information that is not real, then it may affect his judgment and also the drugs to be prescribed, and there may be litigation to face. Actually, in 2007, we supported that idea, and we have helped to do the research. And then by 2011, we have found that the administration is walking away from the path we proposed, and so we withdrew from all committees because we didn't want to be a rubber stamp. Just now, some people said this is patients' information that we are talking about, and some things can be sensitive. In the bill, it is said that apart from the patient and the healthcare provider, the commissioner and people in his office are not going to have any responsibility about the misuse or abuse of information. I think that is not fair. And also, the bill says that the commissioner will promote the system to doctors, but we tried to talk to the administration. However, they were passing the buck around, and in the end, they did not do any preparation for us doctors, except the CNS on RAM. He said that only one clinical management system would be used, and the administration is going to be the banker. If that's the case, why don't you turn the entire health system into a national health service? Then you can be the banker. Thank you, Dr. Young. Next, Dr. Ann Kwan is not here. So let us go to ARPMHA, Mr. Andy Lau, the chairman. Thank you. As a representative of a patients group, we support the EHRSS, and we hope that it will be launched soon, because patients will be able to access their own information. If patients go to a private doctor, he or she will still be able to access his information, so he will get appropriate treatment. The hospital authority and private doctors can share information, so medical records will follow the patient, and that would mean savings in terms of time and money. We understand that it is important to protect patients' rights and privacy, but I think at the present stage, patients only take part voluntarily, and patients must authorize doctors before doctors can access their information. Whether or not there is a safe deposit box, patients will not be very much affected. As the doctors were saying, doctors know what sickness you have by just looking at the drugs that you have been given. And under this EHRSS, and I'm talking about kidney patients. Sorry. Doctors will know that what drugs we are put on. Say we need to take drugs that help our bodies not to resist certain drugs, and if that is not made known to doctors, it may be a health risk for us, so we support the program. Next, Mr. Ng Kwok Kang. Good afternoon. As an average citizen, I think it's a very good system. Doctors have all my medical records, and they will be able to diagnose my sickness more accurately. And also for patients, you do not have to look for records from every doctor you have seen. But on the other hand, I tend to agree with the Privacy Commissioner in that we should increase protection for sensitive data and also to provide a safe deposit box. And then I also agree that we should be able to have access and also amendment rights. As a citizen, I think the law should give us protection so that we are assured to authorize more doctors to share our information through the system, so the system will be more comprehensive. And I hope that the sharing system will not just be for our checking for information, but we should have an online account so we can give authorization, we can check data, and also we can update data. And in fact, we should be able to use the data and ask private organizations to provide service to us. Thank you. Next, Hong Kong Computer Society, Mr. Gabriel Lam. I will speak in English.
So I'm speaking on behalf of the Hong Kong Computer Society, which represents over 9,000 members of different categories. The society supports the implementation of the electronic health record sharing system in Hong Kong. I would like to highlight a few points regarding this initiative. Number one, it is a good example of public-private partnership, and it provides business opportunity for the IT sector. The eHealth is much more than an IT project. It does not only deliver a new infrastructure for health record sharing, but it also introduced new management and clinical workflow practices. It greatly enhanced patient-centric healthcare, whereby a patient can expect all of his or her medical information are readily available anywhere and no longer restricted to any institution. So while the hospital authority has mostly developed the core eHealth application and infrastructure, but through the eHealth Service Provider Training Scheme, it provides training for IT organizations to acquire necessary knowledge in order to facilitate the deployment of clinical systems. The IT supplier have the opportunity to provide IT services to enhance the private healthcare providers' electronic clinical system for the eHealth connections. So it is critical that the eHealth must provide sufficient security to safeguard patient personal privacy. The IT service sector has the opportunity to complement the hospital authority development effort by providing IT advice and services to the healthcare provider to ensure the security and privacy protection are optimally implemented. So last but not least, this is a complex project. So the government should pay close attention to project and risk management to ensure the quality and to avoid any delay of the project schedule. So in conclusion, we believe the successful implementation of the eHealth in Hong Kong will further strengthen the Hong Kong IT industry as Asia-Pacific regional leader in hospital clinical system, as well as regional health information network. So we strongly believe the eHealth will bring great benefit to all residents of Hong Kong, and would therefore urge the LegCo to approve the passing of this bill so that the public at large can enjoy such benefits sooner. Thank you.
Thank you
very much, Mr. Lam. Next, the Association of Licentiates of Medical Council of Hong Kong, Ms. Rainbow Lee. Thank you, Chairman. We have already submitted a written statement. I'd just like to add one point to it, and that is about the safe deposit box. We believe doctors should be able to know the sensitive information about patients. That's the only point I'd like to add. Thank you. Next, Mr. Alan Chang, Privacy Commissioner. Mr. Chang, I'd like to really thank you for coming along today. We have made the arrangement because we like to give you the first opportunity available to speak, but I'm sure members have many questions for you. And we'll follow the procedure. You will be given 3 minutes, but I'm sure if necessary, we will give you more time to answer questions. But in fact, we'd like to beg your pardon because there may be opportunity for us to have to get you back here on another occasion. But here, I'll give you the 3 minutes. Thank you. Chairman, thank you. We agree to the setting up of the EHRSS to facilitate medical workers in getting the necessary information so they can provide appropriate treatment to patients. However, this is not going to include sensitive information about patients, and therefore we have this request towards this bill, and that is privacy protection should not be lower than that afforded by the present PDPO. In fact, it should be further enhanced in order to tackle the sensitivity of the information. But the bill as it stands is not going to do that. Especially, there is one important principle in the bill, and that is data for the patients will be provided on a need-to-know basis. In other words, that the EHR will be shared only on a need-to-know basis. However, this important principle is not in the provisions of the bill. That is not ideal. From what I understand, the administration will formulate a so-called code of practice in order to entrench that principle. However, that is only an administrative undertaking. There is no statutory backing for this. Therefore, it is not clear where the duties and responsibilities lie. And in the future, when the system is in operation, then people who are unrelated will be able to get sensitive individual medical record even if they have no need to know it. Now, in my mind, an ideal sharing system is such that the relevant medical records should be systematized, and each medical worker should be able to have a certain limit to his search powers. But now the bill as it stands does not give me the confidence that you are going to limit the capability of medical workers in searching for information. And later on, it is said that the commissioner will have to monitor the use of the sharing system. However, the bill also says that the commissioner has no responsibility to inspect the entire system, including the electronic records of health provision workers. So it seems the commissioner has no duty to make sure that everybody that uses the system should abide by the law. I think this is mind-boggling. If the commissioner is not going to do the inspections, then who will be the inspector of the entire system? If you do not do inspections, how can you monitor the workings of the system? So we object to that point. And also according to the bill, if patients would like to authorize other people, so other people will be able to do a search or update the medical records on his behalf, this is not allowed. Then I think that is problematic, because if the patient is really very sick and it happens that the relevant medical record has to be corrected or rectified, then the doctors will not be able to get the updated correct information. And he may come to the wrong judgment as to the disease. So we object to that point as well. And time is up, and I have no time to get on with the other points. I hope I will be given time to speak again later.
If the deputations don't agree, I think perhaps I can allow the commissioner to finish what he had to say. Originally, we've scheduled 3 minutes for each deputation, but I'm sure we will all agree, will not object to allow him more time. Yeah, thank you. There are certain loopholes that need to be plugged. In the bill, anyone who used the computer and without and access patients' records without authorization will be held liable. So the provision would target against hacking, for example. But the wording of the provision is too narrow. It does not regulate people who would access unauthorized, who have make unauthorized access to information, not through the computer. Let's say when medical practitioners, when they use the medical health record and they fail to log out from the computer and allow other people to record through visually such record, or use a camera to record such data, doesn't mean that the administration will not need to do anything about it. So I think the government should make some amendments to tackle the issue. The bill also refers to the consequences of improper use. What about improper use of electronic records? The bill mentioned that if these records are used for direct sale purposes or used to make a profit, or if it causes any damage to the data owner, it will be a criminal offense. But there may be circumstances in which the abuse is not for any particular purpose. It was simply because people are curious. So in these cases, the law does not stipulate what will be the criminal liability. So I think members may need to consider this further. That is, whether or not there should be a criminal liability, which should be clearly defined. Regarding the safe deposit box issue, I, of course, support this proposal because on the one hand, we can respect the autonomy, the discretion of the data owner as to, and also it can, if there is improper regulation of the access of sensitive medical record, then if the record could result, we involve venereal diseases, mental diseases, or hereditary diseases, it could cause embarrassment. Some people say that if you don't have the information in the safe deposit box, then we'll not be able to provide, the comprehensive medical treatment. Basically, I don't think we would be able to have 100% access of 100% of the medical condition of the patient. I'm sure doctors would like to have full access of the information so that he can provide the best treatment. Of course, that would be ideal, but it's not possible in reality. The design of the system is voluntary, and all the stakeholders can, the patients can choose to participate or not, and also decide who can access the information or who cannot. So the medical professionals will not be able to accurately control the information. In exceptional circumstances, like Dr. Ho said, let's say if it is a question involved, a life and death situation, you really want to open up the safe deposit box and you cannot, then it would not be fair for the patient. I think we can deal with that scenario through exemptions. In the PVPO, we have exemption provisions as well. And what is most important is that the patient can make the decision knowingly. If the doctor has already explained clearly to the patient what are the benefits of the doctor accessing such information and what will be the consequences if the doctor doesn't have access to such information, then I think the eventual decision should rest with the patient. Chairman, thank you for allowing me more time, and I will also invite all of you to read the document that we have submitted, in which we have explained our rationale. I'll be also more than happy to come back again to this committee to have further exchanges with members. I'm sure members will have questions for you later on. Next, we have Madam Yi Wen from the Sunhua Herbalist and Herb Dealers Promotion Society Limited. Could you please speak closer to the microphone? The eHealth sharing system, it's a milestone to help the TCM practitioners modernize. It can also enhance understanding and collaboration among Western medical practitioners and TCM practitioners. Through the sharing system, TCM practitioners can obtain information regarding modern treatment, and we all know that TCM has a 5,000 years of history. we we relied on traditional TCM technology. We take the pulse with our fingers. So with the EHR, I think it can help. It will help us make more accurate diagnosis and provide a sounder basis. And it is conducive to helping the TCM practitioners to treat the patients. And also when there are emergency cases, then TCM practitioners can refer their patients to Western medical doctors in a timely manner. According to the paper, there are 13 categories of medical professionals, including listed TCM practitioners. We are registered and listed TCM practitioners. Listed TCM practitioners are also participate in the sharing system. And I think it can help the TCM practitioners to some TCM practitioners will be able to cure complicated diseases by using traditional Chinese medicine. Through the sharing system, we can also access, medical records, and we can also communicate with our Western counterparts, so that with good electronic records, patients don't have to take Western medicine or resort to surgery and have the diseases cured with Chinese medicine. I think that would really be helpful to the TCM industry. So the TCM practitioners and our association, therefore, would strongly support the government's proposal to set up the EHR sharing system. For the public hospitals, if some diseases could be cured by Chinese medicine, it can help, save costs on the part of the government. And if we really need to implement the EHR system, TCM practitioners are rather, are not very. Not many of them are conversant with the use of computers. So I think we can start by learning how we can use the computer to make prescriptions and keep the medical records. Next, we have Ms. Man Po Ling from the Hong Kong Private Hospitals Association. The Hong Kong Private Hospitals Association hope that the EHR sharing system will be implemented with the consent of the patients. Different organizations and medical practitioners can access the medical record of the patients and know about the medical state of the patient, the treatment protocol, the results of examination, whether or not they've gone through dialysis, and so on and so forth. So the timely diagnosis and treatment could be provided and delay avoided. We can also eliminate any problem with communication. So whether we're talking public or private hospitals, large or small, such information could be shared. So of course, the privacy of the patient's data should be protected. If it is not properly managed and there is any leakage, then patients will lose their confidence in the entire system. We therefore hope that there will be more public education so that the general public will know what are the rights and responsibilities in using the electronic health record sharing system. Furthermore, there must be a foolproof, risk management regime and also a system to protect privacy so that the patients will have the confidence to allow their medical record to be put into the safe box, because it can help doctors make accurate diagnosis and the patients will get treatment in a timely manner. Next, we have Madam Chow Suk Ying from the Hong Kong Registered Chinese Medicine Practitioners Association. Thank you. Chairman and honourable members, and the other deputations present. Regarding the EHR sharing system and the bill, we are very concerned about the bill. Our association is the most representative organization representing TCM petitioners. We have more than 6,000 members. Regarding proposals in the bill, we have the following submissions. First of all, we're very happy that through the EHR platform, the government is enacting legislation on EHR. This is very important. Without the protection of the law, it's not easy to develop the system. Our association really supports the EHR sharing system bill. We hope that the bill will be enacted as soon as possible. Once it is enacted, TCM petitioners will be able to, through the EHR platform, access the medical record of patients so that we can better serve our patients. The people of Hong Kong now, the demand for TCM service is increasing all the time. When patients consult TCM practitioners, they also hope that the practitioner will know about the detailed medical condition. Sometimes the patients cannot, express themselves clearly, but if we can access the system and we learn about their allergies, sometimes there are similarities when it comes to allergies, for both Western and Chinese medical practitioners, that will be able to provide treatment in a timely manner. So I think both Western and Western practitioners should have equal right to access information. But this platform, for it to function properly, it will be able to help us, serve our patients in a more timely manner. In the past, we had the system can help eliminate certain malpractices. Say, for example, if a patient consults a Western practitioner and then they consult a TCM practitioner, then he can have 2 sick leave certificates and so on. So the enactment of this bill can help promote the advancement of science and also the collaboration between Western and Chinese medical practitioners. Next, we have Mr. Chair from the Motivator Technology Group.
Hong Kong. Our clients include public and private organizations, hospitals, clinics, and laboratories in Hong Kong, China, and overseas. Our solutions include hospital management systems, specialty management systems, and clinical information systems, to name a few. Our focus and strength in particular is in dealing with the delivery and management of chronic illnesses and acute care, where electronic health records are especially critical and useful. The development of the EHR sharing system is necessary and will certainly help to improve continuity of care across both private and public care delivery. We support the government's initiative and commend the work done so far. That said, the road ahead is full of challenges. Based on our experience working directly with many practitioners in both public and private healthcare sectors, we would like to put forth 3 issues and suggestions for the government to consider for future planning and development. Number 1, there are currently few incentives for doctors or patients to participate in the EHR sharing system. Many private doctors welcome the ability to see a patient's EHR, but what are the incentives for them to change their practice and contribute to the EHR sharing system? With voluntary participation, what are the incentives for patients to be part of the EHR system in face of the privacy concerns? These are extremely difficult questions, but these are the questions that we need to answer in practice, and I believe the answer is available. For example, the government can create or expand programs that would subsidize patients with chronic illnesses such as diabetes and heart disease to seek non-urgent services from the private sector. Such programs will provide more direct and immediate incentives to doctors and patients than promising than promoting the real but less visible benefits of a territory-wide EHR. It will also help to improve the imbalance between the public and the private care in Hong Kong. Number two, the government and the hospital authority have undertaken the development of the EHR sharing system. We agree that it was necessary for the government to take the initiative to build the territory-wide infrastructure, and HA, with its huge resources and expertise, was the right implementation agent for phase one. And CMS on-ramp and CMS adaptation provide a near-term solution to facilitate clinics and hospitals to get on board with the EHR sharing system. On the other hand, the role of the government and HA should be to build the infrastructure, the necessary piping and plumbing, so to speak, rather than becoming a software developer or an IT solution provider to private clinic and hospitals. The next phase should call on the free market dynamics to drive more sustainable development for the long run. And then finally, I welcome and applaud the government's initiative, as mentioned in the previous minute, to develop new curriculums in healthcare IT, and I hope such plans will put into action soon. In conclusion, I support the electronic health record sharing system, and as a citizen and a professional, I also hope to see a faster and broader adoption of the EHR sharing system and a stronger collaboration between the government, the HA, and the local healthcare IT industry to build an effective and robust platform to improve healthcare management in Hong Kong.
Okay,
thank you.
唔該謝生。下一位。
Thank you very much, Mr. Chen. Next one, Dr. Chang. Thank you, Chairman. I work in a public hospital. I work in the front line. I have used EHR for over a decade. Within the HA, electronic health records have been developed so that it is widely used in all public hospitals, and it has helped us enhance our service quality and efficiency in terms of accuracy, safety, and the immediacy of services. We have all benefited, and in fact the system is indispensable now in our daily work. After the implementation and our experience for over 10 years, the HA has also developed a system which is quite effective in protecting patients' privacy. Basically, we have set limits to the ability to access and also deposit information. I therefore totally support the HRSS. With regard to the safe deposit box idea, I have certain reservations. First of all, I don't think it is very necessary because all medical workers are professionals. They need to abide by professional ethical standards, and they all place emphasis on patients' privacy, including sensitive or non-sensitive information of patients. They will not disclose or leak the information lightly. If you have safe deposit boxes, it might impact on the trust between doctors and patients, and treatment may be affected as well. Secondly, in fact, a safe deposit box may not be safe because if doctors put certain things on the record, those things are going to mean a lot to doctors' accurate diagnosis. Say, a dentist. He has to use anesthetics. He may need to know the patient's eye history because the anesthetics may affect a patient who has an eye disease. And an oncology doctor may need to know whether the patient is affected by AIDS, because if it is an AIDS patient, then he may not be able to withstand the impact of chemotherapy. Therefore, a complete health record is crucial. As the Privacy Commissioner said, even if we cannot have 100%, we'd like to be as near 100% as possible. Number three, we think the safe deposit box may not be very practical, because the data of patients will be dispersed in different parts of the record. If it is AIDS, for example, it may be on the record. It may also be reflected in the drug prescription list. And it's not easy for you to remove all the relevant information from all the different parts of the system. Thank you. Next, Hong Kong Dental Association, Dr. Johnny Wong. Thank you, Chairman. Good afternoon, everybody. The Dental Association has already submitted a written statement. I'd just like to add 2 points, please. 1, doctors' training, and 2, sharing, the word sharing. 3-4 years ago, the Hong Kong Dental Association and eHealth have formulated the DCMS. This is a dental clinic management system. We designed that system by making reference to the Hong Kong University Oral and Maxillo Medical Information System. The system is quite comprehensive, but there was difficulty in operating the system. And we have also met up with difficulties in training dentists. If you have seen a dentist, you will know that we always work with saliva and blood, and we need to control cross-infection. When I talk about doctor's training, I mean you need to spend more time in looking at patient's record, and on the other hand, you are also a person who executes the work. And in this aspect, we met up with problems, but it is good that the eHealth has continued to support us. Now, there is another project where doctors take the eHealth to an elderly home and help to see patients. We found that eHealth has to be improved in many aspects, and many elderly people have found that they did not have to carry their records around, and in fact we can just use the system at elderly homes to do examination of patients. However, in the process, many doctors have shown concern towards this word sharing, because most of our members are private dentists. Now, to what extent will sharing be done? The major premise is to protect patients' privacy. And privacy includes how much is charged, and not many people would like to allow other people to know that they have dentures. So how do we strike a balance? I hope the administration can do more in this aspect. The Hong Kong Dental Association supports the HRSS in concept, but we need to look at the details and also the point of continued training. And also, let me add, at the Hong Kong U, the eHealth that we are using is not the same that with what you are talking about. The two may not be interfaced. I hope in the end we can be interfaced and we can share the information. This is one of our concerns as well. The other points are in the statement. Thank you, Chairman. Thank you, Dr. Wong. Next one from the Hong Kong Academy of Medicine, Dr. Jean Choi. Thank you, Chairman. The Hong Kong Academy of Medicine would like to make 4 points. We have made our submission in English, but I'd like to add to that. I understand that you are very concerned about privacy and also the system of having a safe deposit box. But let me help you to understand the HRSS properly first. In fact, we are not talking about a complete record. It is only that part of the information would be put into that system. I think Hong Kong people don't only see one doctor. When you go to different doctors and you tell a doctor what should not be uploaded to the system, the doctor should basically follow your request and do as you tell him. So if you talk about a safety box, I think you first need to understand that in fact the sharing system does not include a complete record. Since I'm a frontline doctor, I can cite an example. Say the wife of a man may see different doctors, and if the man in the end contracts VD, he certainly will not go to a doctor the wife sees. So he goes to another doctor, and the man will say this part of the information should not be uploaded to the system. But if the wife and then comes to see me, then of course I know that part of the record of the man. And particularly for family patients, we may be seen by the entire family. But if the father has done something like that, he will not come to see me. He will choose to see other doctors. Therefore, there will be an impact to be done by the safe deposit box. The Commissioner of Privacy says if it is an urgency, if a man is hurt in a traffic accident, and if he is ferried to the A&E department, then who will be given the authority to open the safe deposit box for crucial information about this man? Now, I think if members of the public trust the professional ethics of doctors, then they should not be worried. Thank you. Thank you. I think all deputations have spoken. First of all, let me ask the officials to respond. And that is Mr. Sidney Chan, Head eHealth Record Office from the Food and Health Bureau. Can you answer the questions mentioned by the deputations? And then after you have spoken, the floor will be open to members. Mr. Chan. Thank you, Chairman. First, I'd like to thank all deputations and individuals for coming today and for the views you have expressed on EHRSS. 2 years ago, we conducted public consultations. Some of those views have been known to us, but there are new views as well. And after listening to you, we will go back and provide certain answers in writing. But I have written down a few categories of views, and I'd like to respond to those now. Basically, most deputations support the HRSS. You support the concept, and you say that you want it launched ASAP. I'm so happy to hear that. I'm so happy to know that you have not lessened your support for the system over these years. Secondly, some have mentioned the provisions in the bill, saying that some are not clear enough, that some are not comprehensive enough. Now, at the next meeting, when we provide a written response, we will address those. But one of the points made has also been made by members in previous meetings. I think when you say the provisions are lacking, you have mentioned the patient's safe deposit box function. Actually, in the 2 previous meetings of the Bills Committee, I have said that the administration has not come to a conclusion. However, we will do a research as soon as possible to see how we can design that safe deposit box and what are the pros and cons of different designs, and whether there are examples of success or failure overseas. I hope that we can do this as soon as possible, and then we'll consult the public and the Bills Committee again. This is what we explained to members at the last meeting. And then some deputations talked about the Chinese herbal practitioners. They are very glad to see that this is mentioned in the bill already, but they would like the administration to do more to promote the use of electronic records by traditional Chinese medical practitioners. We agree. We understand that apart from what is provided for in the bill, that TCM should be able to take part. First of all, we need to understand that this is a trend. And secondly, when you use e-records, you must know some jargon. Say you might like to give a code to certain diseases, and that Chinese medicine should also be given a certain way of expression.
係即係做多啲嘅即係呢個推動電子化中醫嘅用語同埋中醫診所，佢哋有適合嘅電子軟件嘅工作。咁呢個係關於中醫啦。咁另外有幾位係即係由資訊科技界嗰邊嚟今日參。
The sector, several deputations from the IT sector also made the point that basically they support the proposal. Several of them asked whether or not we could step up the training, that is, for the users of the HR that is the medical practitioners, should they be given more training courses to help them acquaint with the EHR system? And some ask whether or not we can reflect to the tertiary institutions that we should organize more courses on medical technology. We've heard all those comments, and also there were deputations who suggested that at the next stage, while we should implement EHR SS as soon as possible, there are two topics which many people have expressed concern. First of all, the safe deposit box, and secondly, a platform for the patients to access his or her own electronic health records so that they can make adjustments or corrections. Some IT deputations from the IT sector told us that we should they want the government to work with them as to how we can introduce more functions into this system, and that we can be kept abreast of what are the latest technologies. So I hope we'll certainly, and relate all these points to our partner, the HA. There were also suggestions concerning what sort of information will be shared, and also there are certain protection measures mentioned in previous consultation. For example, the need-to-know basis, the voluntary participation scheme, and why these are missing in the bill. The need-to-know basis or the voluntary participation, why we have not seen those terms in the bill. I think I might need to make a supplement here. Of all the provisions in the bill, many of these provisions already highlighted these principles, the need-to-know principle. That is, it's only the patients under your care whom you have the right to access the information. Voluntary participation, we may not use the exact word in the bill, and there may not be a definition for that in the bill. But the design of the provision is based on those principles when they were drafted. And that is why we're saying whether you're a patient or a medical institution, you need to apply before you can join the scheme. So that would mean that it's voluntary. As whether the information could be abused or whether or not it should be used on a need-to-know basis. So in the bill, we stipulate that the EHR data can only be used for healthcare purposes. A secondary use might be that under certain circumstances it could be used for medical research. And secondly, one should not think that the data could be used for any purposes or just because you're curious, you want to use it and disseminate it to gossip columns in newspapers and so on. So this is how we express the idea of the need-to-know basis. But there's some protections which cannot be, protection which you cannot rely on the wordings in the law. For example, we have to help the patient understand what is the purpose of the scheme, explaining the content or the rationale for the HRSS. I think it's not appropriate to write down such explanation in the bill. But in our correspondence with the patients and when the patients apply to join the scheme, we will provide further information to them about the spirit of the law. And so this is my preliminary supplement as to why certain wordings have not appeared in the bill. So basically, these are the few major points that I've heard from the deputations, and if the chairman and other members of further questions will be happy to respond. I think the 6 points made by the previous commissioner, I don't think you have responded to them one by one. So do you think that you would like to do that now, or well, the previous commissioner has already submitted made a very detailed written submission. So would you like to respond to those points one by one? I can prepare a written response, but I can also, well, the commissioner said that in 6 areas we've not accepted the commissioner's proposals. Actually, we have reasons for that. So if you have given me time, I can, say something now, and I'll give a written supplement after the meeting. Referring to the submission from the previous commissioner, there are 2 basic principles which we agree with. That is, first of all, even if we're going to have the EHR SS in the future, we will still be governed by the PDPO. And the commissioner also emphasized that when we implement this, if we implement the scheme, we should not weaken the powers of the previous commission, and we agree in principle to that. So the third basic point which the commissioner also touched on was that the PDPO at the moment, provide for the minimum, stipulate what is the minimum protection. Of course, if we could do better than that, fine, but we cannot do anything less than what is the minimum requirement. And we have no question with that principle. So in the bill, one part of the bill says that except for a few areas which need to be changed, the rest of it we have follow the PDPO. Some have been highlighted in the commissioner's submission. First of all, the definition of minor. According to the PDPO, it's 18 years old. According to our bill, it's 16. There is a medical justification for that. And secondly, under the PDPO, the data subject can allow different categories of people to access his information or to amend his information. That is this concept of substitute decision maker. I think we've adopted the same concept in the bill. We allow several categories of people to be substitute alternative decision maker, including minors or people who don't have the capacity to make decisions. That it could be the parents, the family, the SWD, or a person appointed by the court. So this is more or less the same as what is provided under the PDPO. But there is a category of people under the PDPO. That is, the stated subject gives a written authorization to either a friend or like his accountant or someone, a third party that he trusts. Under the PDPO, the data subject can authorize in writing another person to access the information or to amend the information on his EHR. In the EHR bill, we do not provide for this category of persons. So it's under our scheme. The person who can represent the data subject to make that request is small in number. We do not accept someone saying, I have the written authorization from the data subject, I've come here to obtain this information, to access information. Well, this is because we want to have an even more stringent requirement. We want to further narrow the scope regarding the number of people who are eligible to access information or amend information on behalf of the data subject. In drafting the bill, we've heard one view, that is, those who are vulnerable or the elderly persons may be or may be cheated by unscrupulous employers or dishonest persons who might be fooled into signing a power of attorney. And then if such person will say, I have the power of attorney, I've come here and I want to collect the electronic health record of this person. We've heard such a view in drafting the bill, and we felt that's how we've narrowed the scope. We've eliminated such categories of persons. So even if your unscrupulous employer forces you to do something, or someone dishonest try to cheat you and ask you to give him the authorization and then come to us for your medical record, he will not be able to do that. Furthermore, the EHR, so we want to offer more protection for the patients. So if the public thinks that we shouldn't further tighten the scope here, that we'll be happy to consider whether we should relax it again. I'm sure you'll be giving us a written submission, a response anyway. So I think we should now first, let members ask questions first. I don't know what the time management should be. Shall we say 5 minutes per member? I think we should allow the opportunity for members to ask questions. We'll start with Pamela Lau. Thank you. I'd like to thank all the deputations for coming here to give us their views. We'll certainly consider the views carefully so that we can balance the concern of all the stakeholders and come up with a system that will actually protect public interest. The previous commissioner, according to his submission, told us that the authorities have not accepted all the suggestions. In paragraph 27, we're told that they participated in the working group, and I don't know why, despite the participation, we still have so many problems. The director said, so I hope the director will, well, the commissioner, I think most of what the commissioner said I found to be very reasonable, the deputations. And so I hope that the commissioner will give us a detailed response as to how you would put those things into the bill, as some deputations pointed out that they've not found those in the present bill. I would like to ask a question which I asked before. That is, private medical practitioners, some of them don't use doctors. We heard even more shocking news today. Originally, we heard that 1/3 of doctors don't use computers, and then Dr. Yang told us that 3/4 do not use computers. I don't understand. You're also very well educated. And people have been complaining that you scribble on your medical record, and even the nurses don't understand how to read it. As a result, they dispense the wrong drugs, and the patients don't know how to read either. And over all these years, you refuse to use the computer. The government is now subsidizing the senior citizens to consult private practitioners. So, and then there were suggestions that I don't think the doctors are asking the government to give them a subsidy to install computers. So if many of you are not using computers, how can we implement the system? And then Professor Bacon-Shone referred to the committee. The director has not responded to the point that in Section 53, the EHR or the electronic EHR review committee, the professor has put it most correctly. You say there are 10 people, but most of them are doctors. The recent case, which have been investigated for 9 years, just look at how angry the parents were. The professor, we will just follow the past precedent, but all the penalties dished out in the past have been too lenient. Many members of the public respect the doctors. They think they are gods. They always say, this is what the doctor ordered. Of course, we all respect our doctors. When we're sick, we need to consult the doctors. But I don't think we should give them too much power and authority. So the professor was right. You should clearly tell us who are the people sitting on this committee. There should be a proper balance. Don't let it be monopolized by the doctors. What about the patients' rights groups? So I don't think there are many of them being proposed to sit on this committee. Whenever we see the term committee, other than, I really hope that we can have the right balance. And also, to repeat the same question, why are the doctors unwilling to use computers?
We are not in the Stone Age. Who are you directing the question? Dr. Yang? Please do not scribble your prescriptions anymore. Even doctors cannot read other doctors' handwriting. Dr. Yang? Thank you, Ms. Lau. I told you the figures. They are real figures. I never said you lied. The thing is, the 1,000-odd doctors who use the computer mainly to print out the drug label only. the clinical history is not really carried on the computer. The drug labels are also very important because the Academy of Medicine says we should not make any mistakes with the drug labels, so doctors use the computer. But many patients told us that if they go to HA, the doctors would only look at the computers and not the patients. But private doctors look at the patients, not the computer. We place emphasis on doctor-patient relationship. If we only look at the computer, especially if you are not exactly literate with the computer, doctors may have to spend too much time looking at the screen instead of looking at the patient. So doctors are having patients' interests in mind. But in the EPR, some doctors have taken part because they can get information from the websites to help patients and also to reduce duplication of efforts, particularly with regard to blood tests or x-rays. And through the system, we can help patients. Just now I said that later on, if there is too much information on the EHRSS, every doctor would be feeding information into it, whether you go for skin disease or influenza, then there would be too much information, and it may affect doctors' judgment. But if it is hospitalization, then that is important information. But minor ailments are not exactly important. Dr. Ho, please be very quick. Ms. Lau asked why we have different percentages. This is because we are talking about different timing. I have been a doctor for 40 years and no doctors used it when I started. But 20 years ago, 15% of doctors said they used the computer. And recently, I have come to know that 60% of doctors are using computers. So both are correct. Dr. Young and other deputations are correct because we are talking about different timing. More and more doctors are using computer. New doctors who have been using computers at the HA would certainly do so when they start private practice. And of course, we have started a project ourselves. We have created a CMS for all private doctors. Now 600 doctors are using that CMS, and it's not a small number. Okay, thank you. I think you have answered the question. Dr. Joseph Lee. Thank you, Chairman. Chairman, I'd like to thank the deputations for coming and telling us our concerns. I'd like to thank the deputations because many of them support the EHRSS. I think this is a better effort done by the administration because before we heard that the pharmacists were all up in arms against this. Chairman, talking about EHR, I heard that you have already got one system which works. Maybe there is one for HA, one for private hospitals, and another one for private doctors. Next time, officials, can you do a demonstration for us? What are we talking about? We are legislating to regulate something, but what is that we are going to regulate? You need to show it to us. Some people might not have seen it. Some doctors might not have seen anything like that. And even members might not understand it too well. So I will ask you for a demonstration at the next meeting so members know what we are legislating for. Secondly, I heard some deputations say that patients should be allowed to access and modify information. Well, I think that is technologically possible, but this brings me back to the last meeting when I said that if patients are allowed to access and modify information, then everything would be in chaos. Now this is not allowed. Medical workers do the recording and then that will be kept as a record. As a doctor said, if you come to see me, that means you trust me. And if you ask me not to expose certain information, I will not do it because that is my professional ethics. But just now you said patients might be able to access the record. Then I think that would be a wrong message for the patients in that they are able to modify the records. As I asked last time, is it that the record should be possessed by me? Is it that I have ownership? And will I be able to print a copy whenever I like? But that's not so. At the moment, patients will have to apply for the record, and then the record can be shown to a private doctor. That is why you are trying to legislate for a better system. But I think, first of all, you need to clarify all these. There are some patients groups here, and they may have this false expectation that if they support the system, they will be able to access and modify their own information. But that is not the case. You can only authorize other people to see your record. In your response paper, you did not address this point. The Privacy Commissioner answered certain parts of the question, but I still would like to ask you not to give false hope or expectation to the doctors, to the patients groups, because there may be conflicts created between doctors, nurses, and then the patients. Some people have mentioned the safe deposit box issue. I think this can be easily resolved, as the doctor has said. If you tell me, please keep this part of the data confidential. Well, I can highlight this particular part when I type in the information. I can say this is a promise that I have given to the patient that this should not be disclosed, and all doctors will know it. You don't need a safe deposit box. This is a so-called technological arrangement within the industry. You don't need to use a very state-of-the-art technology. You have not written this into the bill, but you have to resolve the problem, or else there will be a lot of disputes. Chairman, I would hope that Mr. Chan has heard us from the industry and also patients groups. Please think hard about this when you go back, or else I don't think we should go into clause-by-clause examination so soon. Do you want him to respond to you now? Well, I have given some proposals. That is, we need to have a demonstration next time, and also the safe deposit box issue. In fact, at the panel, a visit has been arranged to the HA. No, Chairman, some private doctors have told me, or have told us here, that they use computers but not for this purpose. Maybe they should demonstrate also to private doctors. That is very easy. You just have to upload the software and then you can use it. However, I don't want doctors to only look at the computer screens and not look at patients. Well, okay. Please consider doing a demonstration to members and or doctors. Next one, Ms. Elizabeth Quat. First of all, I'd like to thank deputations and individuals for coming and for giving us very valuable views. I have been promoting this more than 10 years ago, and now the administration is willing and is working hard on it. I will support it in principle, of course. But after listening to deputations and after 2 Bills Committee meetings where I have asked many questions and which are not answered, I now have some worries. Chairman, in fact, many of the points raised today have been covered in our previous 2 meetings. I find it a little strange because what the administration is telling us is quite different from what the professional bodies are telling us today. Just like the Privacy Commissioner, I think his 6 points are very valid, and they are hardly debatable. Say, for example, the Privacy Commissioner said, if you take a picture or you do a handwritten record, does it mean that this will not be a crime? I have asked that question. The administration said even under the present PDPO, those acts would be regulated already, so you do not have to say that these are offenses under the bill. The Privacy Commissioner is here today. Please let us know whether the administration's answer is reasonable. Later on, which commissioner will be responsible for this? Mr. Alan Chang. Chairman, I think there is a difference. We are legislating for a new law, and we have to think about the consequences of different scenarios. we are talking about handling very sensitive personal information, and in certain circumstances, criminal offenses might be committed. In the PDPO, we have a general kind of regulation. And basically, we are talking about the flouting of DPPs, and the consequence is not criminal. We just say that we confirm a data protection principle has been flouted, and we can only issue an enforcement notice. If the enforcement notice is not followed, then we can refer the case to the police, who will study whether there is any offense committed. So it is not very strict, and therefore there is a difference. Since we are talking about electronic records, we should concentrate on whether we should provide for stricter penalties. If you only rely on the PDPO, well, you can still achieve the basic regulation, but in fact, we are talking about sensitive information under this present bill. Chairman, we are discussing very serious issues. I will invite the Privacy Commissioner to come to our next meeting for a detailed discussion. When the administration has come up with a written statement, I hope the Privacy Commissioner can come along so we can have a tripartite discussion. I still cannot come to a decision today after listening to the deputations as to whether I should support the bill as it is or whether we should go for a safe deposit box before we pass the bill. I think the Privacy Commissioner has already said that he is willing to come back. And at the next meeting, when the administration writes a response, then we can have this discussion together. 4 more members are queuing up. If I keep the present pace, we will exceed the meeting time. If members do not object, we will allow the meeting to be extended by 5 minutes. So we have 4 members. Dr. Fernando Zhang. Fernando Zhang to be followed by Alan Leong, Alice Mack, and then last but not least, Dr. Leung Ka Lau.
Thank you, Chairman. I'd like to thank the deputations as well for coming to give us their views. Of course, we understand that the safety box, from the medical perspective, they need all the full details before they can make a decision. But then it is also important to protect the privacy of the patient's data. So Professor Shone made a valid point. The government has promised to give us a written response to the points raised by the Privacy Commissioner. That is also important. The government should give us a clear explanation in respect of those points. I say whether it's a question of liability and whether or not that should be a criminal, whether we should clearly spell out whether it's a criminal offense, so that people will not abuse such information and get away from the criminal liability. So the government should give us a response. The director told us that the data subject, in certain circumstances, can allow other persons to access or correct his information, and this would involve people who are mentally incapacitated or minors. But I'm worried about those who are mentally retarded. They may already be adults. According to the definition, they're already over the age of 16, and after they have become adults, do the parents have the power to access his or her information when he has become an adult? The system of guardianship is rather passive. It's a kind of a last resort. I understand that the guardian is also not vested with such power, that is, access of the the medical records. So how do you intend to deal with this category of people? And also, you have regarding the data subject given written authorization to someone to access or use this information, you've done away with that. And I think this involves the work that we do. Sometimes we receive complaints from patients asking us to help them deal with matters relating to medical incidents or follow up on certain disputes relating to the medical medical incidents. If we cannot represent the client to ask for such information, the client could be old, senile, or handicapped, and they may not know how to access such information. So two questions. So could the administration respond to my two questions regarding accessibility of information? Several members asked various questions other than Dr. Cheung. Could you focus on responding to Dr. Cheung's question? He asked two questions, the question of guardians and medical incidents. Dr. Cheung said that certain persons may already be over the age of 16, they're adults, but they cannot make a decision on their own as to how when he wants to access or amend his record. So would it be possible for someone else to do it on his behalf? In the way the bill is drafted at the moment, says that so long as we satisfy the legal definition, the MIP, if the person is mentally incapacitated, then several categories of persons can act on his behalf. Dr. Cheung's second question was that some people could be physically very ill, and they have difficulties in applying for the access of information or apply for his data to be amended. So this hinges on how the public sees, who are the people who will be allowed to act on behalf of that person. Under the PDPO, it would include people who have the written authorization. In the course of drafting the bill, we've heard some people saying that we want to protect certain category of people so that they will not be cheated by unscrupulous employers and so on. So this is how we have drafted the bill at the moment, but I'm interested in listening to your view as to whether or not the provision of the bill is too stringent or not. I think the director will understand that many people who are suffer from mildly mentally incapacitated, so they will not be classified as such by doctors. So these people are not mentally incapacitated. However, the parents or the guardians would still need to have access to such information. So we must deal with that in the law. I'm sure he will go back and take a look at this point. Yeah, and give us a response at the next meeting. Mr. Allen Lew, thank you very much. I'd like to thank the Deputations for spending so much time to share with us your views on the question of the HRSS. Chairman, if a patient wishes to seek more than one medical opinion, if you allow his medical record to be shared through the EHR, that would really be most helpful. But what the civic party is most concerned about is whether or not the patient has a choice, and whether the patient is taking a risk that he can, a privacy risk that he can withstand. I'm rather shocked to hear, and that having heard all the deputations, especially Professor John Bacon-Shone's view, I think I'd like to know why this is originally something very good, and now the government has turned into something that is not so good. Professor Bacon-Shone is highly qualified. He is a part of the audit team for the Privacy Commission. He had also developed electronic health records systems and so on and so forth. But when I read the professor's conclusion, he is that what he is worried about. He's saying that the government has turned a deaf ear to his concerns. And I don't understand the government's position all along. The government is saying that for the concept of the safe deposit box, the government has maintained an open mind. So why are you asking us to endorse this bill? It's not logical. Because if whether or not the patient is a choice as to whether or not he or she should withstand a major privacy risk, that is the major focus of our discussion on EHR. You're saying that let's have the safe deposit box and then we will then deal with the question later on. And I don't think that is acceptable. So two questions. First of all, a question for the Professor Bacon-Shone. If he is so knowledgeable in this area, could he tell us that is for other countries which are also implementing the EHR-SS, how do they deal with the concerns expressed by the professor? And secondly, Dr. Chai Wei Wang, I have a question for him as well. He said that so long as you trust the expert opinion of the doctor, it's all right. Even the husband has VD, but according to the EHR-SS, the professional judgment of the doctor, where does it give the protection for patients? Perhaps I'll ask the professor to answer my question first. So the professor, followed by Dr. Choi.
The issue of other systems, this is exactly why they're having very fierce arguments. That's why the UK system has been put on hold, because the patients are not happy that they understand what they're agreeing to. So this is exactly the problem there, the same sort of problem. And again, the doctors insist we must see everything, which is completely unreasonable in a situation where, in Hong Kong in particular, you have always been able to make that choice. You go to a private doctor, they don't know anything except for the medical records you take along. So I think this is a very fundamental issue that needs to be addressed.
Can you try to speak into the mic?
Sorry. So I think this is really an essential component to it, and I don't think the answer that doctors need to see it all is a good answer, particularly because, as the Commissioner said, we can have an emergency exemption. That's not a problem. So I understand entirely. If I'm unconscious and I turn up in a hospital, of course I want the doctor to see all of my health records. But I think the other critical difference with the UK is in the UK they're setting up a new system. In our case, the hospital authority already has around 20 years, I believe, of our data, plus it's not just the hospital data, it's the Department of Health data. And you have no choice as to which of your HA and DH data goes into the system. So if you've ever been to a DH clinic and they put it into their system, it will appear in the system, and you have no choice. And that's again defined in the legislation that you cannot opt out of those parts.
Well, dear Professor, the administration is not listening to you, but we are all ears. Are you so kind as to help us by providing us with a summary of the way forward in respect of all those points that you made to the administration but fallen on deaf ears?
Well, I can, for a start,
we would welcome your further elaboration and submission.
I'd be happy to come back. I'd also be happy to show you the submission I made during the consultation period.
Thank you very much.
Yeah. 蔡醫生。
多謝梁議員嘅提問。
For family doctors, parents, children or grandchildren, normally they go to the same family doctor. But when the parents both consult the same doctor, I'm running out of time. Dr. Choi, my question, I really believe in you. I really trust my family doctor, let's say. However, my trust in you does not give me the confidence. What the government is now proposing, the system that they are proposing, your professional integrity is nowhere found here. It doesn't affect the system. If the patient tells the doctor, certain information of mine I don't want you to upload onto the record, basically the doctor will not do that. Okay, I understand now. So I mean the information need to be uploaded and put into the safe deposit box. Once you upload it, it's already exposed. But what the patient understand and know how to do this is something else. All right. I have extended our meeting by 5 minutes, and we have 2 more members, so perhaps we may need to extend the meeting by more than 5 minutes, 10 minutes perhaps. So, Elsmac, Chairman. First of all, I also like to thank the deputations for coming to meet with us today. I also like to thank the professor and the previous commissioner for explaining certain technical details with us, and we certainly would like to learn more about the experiences in other jurisdictions in particular. So today I would like to speak in my capacity as a patient. I consult both doctors in the public hospital and private practitioners. Both of my legs, I have operations on both of my legs several times. I had my legs treated in the public hospital. It's convenient in the HA because they use electronic records. Everything is stored in the computer. Although some patients complain that the doctors tend to look at the screen than the patient. But anyway, we understand that in public hospitals, the doctor cannot spend too long a time on each patient. They will take a few look at the question of the patient, and then they'll have to concentrate the monitor again. The advantage is that when I try to veer, look at what he's trying to type into the computer, I want to find out whether the doctor is mentioning my right leg or the left leg on the record. So that I want to find out whether he's got the record wrong. And I don't mind the doctor watching the monitor because the patient can also do that. So I think that there's still some protection for me as a patient. So first of all, I hope the private doctors would. That doesn't mean that if you need to attend to the computer, you would spend less time with the patients. And on the other hand, I've seen private practitioners, if I see ophthalmologist, and he will use a hand to write down the medical record, and I could not, try to, steal a look at what he's writing. So, using the computer will help protect the patients. So I think on one hand we need the assistance of the doctors. That is, a doctor should be willing to take that extra step for the benefits of the patients. And also the patients would need to be able to trust the doctor to upload this information onto the record. So I think we need the safe deposit box. Many of my friends in the IT industry say that nothing is confidential on the internet. Things that you don't want other people to know, you shouldn't upload it onto the internet. If that's the case, there are many people like myself. I don't believe, because things that I don't want other people to know, I would simply not upload it onto the internet. I would then ask my doctor not to upload any of my medical record onto the system. So what purpose would the system serve in that case? And thirdly, I agree that there should be a platform for patients so that the patient can access his own medical record. Whether you say that I'm being nosy, or I want to learn about my own personal record, I want to learn whether the doctor is saying that there's something wrong with my left leg or my right leg or whatever. If I cannot access my own medical record, I wouldn't know whether the doctor has inputted the wrong information. I think it's very, very important that I know whether or not the operation is going to be on my left leg or my right leg. I don't accept the government's argument that we should do it first and then we should make further improvements in the second stage. Why not do it at one go? Many patients simply say, we don't trust you, I don't want to join the scheme. Why has the government chosen to take this approach? Dr. Ho, I see that you are smiling. So you've asked 2 questions. You asked why the government cannot do it at one go, and also whether doctors are more willing to use the computer. Dr. Ho, to put it simply, more and more doctors are now using computers. I'm talking about the private practitioners, and the trend is still continuing. As I said, we need a patient portal so that you don't need to, steer. So I mean, there should be a portal for you to be able to access the information.
Mr. Chan, why don't you do it at one go? Let me talk about some historical background. 5 years ago, when we applied for funding to design the system, we said already that at the beginning we would set up the core only of this platform. We are going to provide core functions only. At that time, we did not mention complicated functions, for example, for patients to choose what to upload and what not to upload. And secondly, that patients can have a portal to access the system. We already said that in stage 1, we will only go for the very basic design and basic operation. The more complicated or upscaled functions will only be decided in the second stage. And in 2012, somebody mentioned that concept about the patient's safe deposit box. We never said that we would not do it, but it is just that it will not be within the scope of stage 1. Ms. Mack, he is telling you that this was the result of previous consultation. I think we'll revisit the issue later. Last speaker, Dr. Leung Ka-lau. Thank you, Chairman. I have so many questions. When we come to clause-by-clause examination, I think I will take them up one by one with the administration. But let me talk about the overall concept first. EHR is something good. That is not something for debate. Those who know how to use it will find it so helpful. But the thing is, why do you want to legislate for it? I'm not objecting to EHR. That has been used by the HA many years. But why do you want to legislate for it? Either you want to authorize the administration to do something, or you require the administration to discharge a responsibility. And secondly, there may be offenses to be created, so people can be fined or thrown into jail. My question is, talking about the administration's powers and responsibilities, I think a lot of those are being undertaken by the HA without any legislation. And talking about offenses, that if somebody contravenes certain provisions, so that person should be penalized. I'd like the administration to address this. The offenses that you have mentioned are still offenses without this law. Is that right? Many of them are. So which are the new offenses created by this bill? Which are those that will not be offenses without this bill, or there will be only civil liability? Mr. Chan. Dr. Lau asked 2 questions. Why we need a law, first of all. He said that many government services are not provided for in legislation. But for example, the HA is also set up by a law to regulate its operation. The sharing system involves the private and public sectors. It covers a very big area. And secondly, all Hong Kong citizens can apply to join the system. Theoretically, the data bank can be so huge. We believe that a law will provide better protection. This is also the product of our consultation with the public. This was supported by a majority. Secondly, the offenses. Okay, you asked why we cannot cover all the offenses by existing law. Whether you're talking about the PDPO or other laws, they can be used to cover certain offenses. Say if you steal some medical records from a clinic, well, you can call that a theft offense. I'm simplifying things here, of course, but very often when the laws were written, there was not this EHRSS in the whole wide world. This is a new system. And if people break the law later on because of the operation of the EHRSS, I want to say it clearly that you have gone into which part of this system and what penalties there will be. And this will assist prosecution and the court. We have not listed a whole batch of offences. We have included just 6. Before, some offences were not offences. Say, for example, using data from the HRSS for marketing. We are saying here that that is going to be totally prohibited. This might not be in any existing laws in Hong Kong. This is one example from the 6 offences in the bill. But we can tabulate such offences for you for clearer understanding. Right. Please let us know whether some of these offences are already in certain laws and what the penalties are and why you want to create new offences. All right? I asked you the first question and you said this is because it involves both the public and private sector and many patients. But in reality, most patients are HA patients. Many private doctors will have no incentive to upload information to your system because when you consulted people previously, if you talk about a sharing system, I don't think it's going to be a system that shares information because the understanding was that the HA would operate a huge data bank and some hospitals will have their own data banks. Then you would provide a system for HA and other hospitals to combine information. But now you seem to be asking that all data will be stored with you on your system. So it's not a sharing system, it's your system. Is my understanding correct? That all data will be stored with you? Well, allow me to give you a technological explanation. I think this is exactly what Ms. Alice Mack is saying. This is not on the internet. In the end, there will just be one copy. Or else this would be something like the internet. But no, it is not an internet. Well, anyway, half a minute for the officials. Well, no. Let me ask the question this way. No, you have exceeded your time already. We said that we would only extend the meeting by 10 minutes. Well, of course, you call the shots, Mr. Chairman. Your question is very clear. No, my question is, I know that in overseas places, very often they use my concept instead of having all data in your system. In other words, each data owner will have his own database and not for all data to be placed at one place. And the law will regulate the way data is shared. Okay, a simple or short response from you. Number one, it is not going to be on the internet. It is going to be in a system which have a limited access for certain people. And secondly, it is not that all participating organizations will upload all their databases to our central storage. No. Each hospital or each clinic will certainly keep more detailed record for or than what is shared. We're only talking about 8 to 10 kinds of crucial information that will be shared. Clinics and hospitals can still store much more information about their patients. Okay, I think Dr. Leung will investigate this with you later on. This is the time we need to adjourn the meeting, but allow me to say that the next meeting will have to be scheduled later because we need to find the venue. We will issue notices to members. Because it's very difficult to find a time convenient to all. Thank you very much. Thank you, deputations and individuals, for coming to the meeting. Thank you for staying till this late. Thank you very much.